Hello, hello, Ma'am Shivani. Am I audible?
Yes, ma'am.
Okay. Can we start?
ये देखना किस में है, मैं वैसे वीडियो पे आ रहा हूँ। ठीक है सर, ठीक है, ठीक Hello.
Hello.
Hello, Shivani. Good morning. Bhardwaj.
Sir, good morning. Sir, good morning.
I have joined. I think my name is not printed there, but I
Yes,
think
sir.
you can do that, or I'm available. I have joined.
Yes, yes, sir. Yes, sir. Good morning.
Very good morning.
Good morning, sir.
Very good morning, Madam Salini sir.
Good morning, sir. Sir, can we start? Or either we have to wait for 5 minutes more to let some other people join?
Yes, we can wait for next 2 minutes, then we'll start.
Okay, sir. Okay, sir. Okay.
Hello.
Hello. Hello. Dr. Mish, Dr. Camera off आ रहा था ना? How can?
Ma'am Shivani? Shivani, ma'am?
Yes, ma'am.
Kindly resolve the problem of the camera problem of Bhardwaj, sir.
Okay.
Good morning and warm welcome to Honorable Advisor to Chancellor Professor Dr. T.R. Bhardwaj sir, Dean School of Pharmacy and Emerging Sciences Professor Dr. Ravinesh Mishra sir, all dignitaries, my colleagues and my dear participants. School of Pharmacy and Emerging Sciences, Baddi University is going to start the second day of International Online Conference on Drug Discovery, Development and Lead Optimization in the heart of Asia's largest pharmaceutical hub, Baddi, India. Today, our chief guest, Professor Dr. Dulal Panda, Director, NIPER SAS Nagar, Punjab. Guest of honor, Professor Dr. J.K. Sharma, Honorable Vice Chancellor, Baddi University, will also join with all of us. I would also like to thank Dr. Yan for supporting all of us. Yesterday, we have having sessions with renowned speakers, and we have 8 learning sessions yesterday, and it is a matter of pride that we have received 1024 registrations and more than 200 oral and poster presentations for this conference. Now it's time to welcome our keynote speaker, Dr. Yan Deng, and I'm taking the privilege to introduce Dr. Yan Deng. Dr. Yan is Associate Professor of Pharmacy Practice and Administration. She earned her doctorate of pharmacy from the University of Sciences in Philadelphia and completed a specialized residency in ambulatory care at Temple University School of Pharmacy. Her practice site is located at Chesapeake Healthcare in Princess Anne in Pocomoke. Dr. Dang is a member of the Maryland Pharmacists Association and Maryland Public Health Association. She is also certified as an immunization provider and sits on the statewide advisory commission on immunization. She served as the director of global health at the School of Pharmacy and was selected as one of the Maryland's top 100 women in 2009. May I please request Dr. Yan to please share your presentation? Over to Dr. Yan.
Thank you, everyone. Can you hear and see my slides okay?
Yes, ma'am, it is visible and we can hear you.
Okay, perfect. Thank you so much for inviting me to this wonderful conference. I wanted to join you today to speak about a little bit about how healthcare has changed due to the COVID-19 pandemic here in the United States, now that it's been over 2 years since we had it, and share with you some advances in both healthcare and technology that occurred because of COVID-19. So just to give you a quick update about what our progress has been for COVID-19 here in the US, we've had a lot of cases since the pandemic began. We currently, in total, had about 100 million cases so far. But luckily, due to the advances in technology and healthcare, we only had about 1 million deaths. One reason for this was the vaccinations for COVID-19. Here in the US, a lot of organizations, education centers, government agencies, they required people to be vaccinated for COVID-19. So about 80% of our population received at least 1 dose of the vaccine, and close to 70% of our population are fully vaccinated. And these numbers are of yesterday. So with COVID-19, of course, there was a lot of negative consequences with its impact due to healthcare and also health disparities. Here in the US, one of the things that occurred was a lot of people, first of all, lost their housing. So in the major cities here in the US, a lot of people didn't have housing, they didn't have financial means, and as a result of that, they didn't have access to affordable medical care. Also, with the shutdowns, both in the government section and the healthcare section, a lot of people were unable to get medical care access, and about close to 60% of them to see a primary care doctor for at least a year. And with the health disparities, it mostly occurred in the Black and Latino households. So we see a lot of divisiveness along racial communities.
अच्छा.
Okay, so another thing that happened was among children, more than 1 in 3 households with children had serious problems keeping the child's education going, mostly because children during this time, the schools closed, so the child had to stay at home. And this impacted getting childcare, especially for women. Also, for households with children, a lot of the communities didn't have very accessible internet connection. So even though the parents were at home and the child was trying to study, it was really difficult for them to learn. So there were studies about this impact. And here in the US, the average math score of children decreased by about 10 points due to the pandemic. Where I live, it's a very rural community. And here in this rural community, about 40% of most areas lost their jobs, they were furloughed, or had hours reduced due to the outbreak. Here where we are in this school, a lot of people in this rural community also lost their jobs too, which caused a lot of financial and medical burdens. There are other issues. One is, of course, with inflation that has not decreased even after the pandemic, and a lot of food shortages that we're still seeing today. Inflation nowadays typically occurs with either food or gas prices, where the prices go up and down due to supply and demand, but that's one of the consequences too that we're still seeing. Another problem right now that we're facing is housing insecurity. So due to the pandemic, there were eviction notices that got piled up, but because it was an emergency, people didn't leave their homes. The government protected them. However, now that the pandemic is mostly over, these safety precautions have been lost. So a lot of people now are getting removed from their housing. Also, housing prices now are a lot higher than before the pandemic, which makes a lot of disparities. And interestingly, another issue that we're finding right now is that there's a lot of shortages with people in jobs. So during the pandemic, a lot of people changed their professions. So people in things like restaurant businesses, education, healthcare, they actually changed their jobs to other disciplines. So it's harder now to fill those voids. And also with the aftermath, we're seeing more and more people apply for jobs that are more remote, where they can work from home. I think the benefit of the pandemic was that it exposed people valuing more quality of life and being able to spend more time with their loved ones and families. So that's another shift that we're seeing in the job market. And finally, one of the things that the pandemic exposed too was just the racial disparities among the US, where especially minority groups, particularly Black and Hispanic people who were disproportionately affected by COVID-19, were more likely to die due to COVID-19 and had more pandemic-related consequences. So one big topic of the impact of COVID-19 here in the United States was just the impact of COVID-19 on healthcare. So many adults had very negative impacts to their mental health and well-being. So for example, people had insomnia, they couldn't eat, they had increased alcohol and other substance abuse. And of course, they had anxious and anxiety, as well as depression. So before the pandemic, about 11% of patients reported these symptoms, but after the pandemic, this increased fourfold to about 41%. And as we look at these numbers a little bit more closely, a lot of these patients, due to COVID-19, had both symptoms of anxiety and depression, close to 40%. But of course, there were other factors too that increased the risk of mental health. Things like job losses cause more suicide and suicidal attempts. A lot of people abuse substances, particularly opioids and fentanyl. So that increased the risk of respiratory-related deaths in the United States. And we saw a lot more mental health issues, particularly with the elderly, the homeless people, and minorities here, especially if they were diagnosed with COVID-19 and tested positive for it. There are other health disparities that occurred due to COVID-19. So for example, young adults was one group. They experienced a number of pandemic-related consequences, such as the schools and universities being lost and their jobs being lost. So this contributed to their poor mental health, and particularly adults between 18 to 24, they have very high rates of anxiety and depression. Also, research also showed that job losses is associated with increased depression, anxiety, and distress. And of course, these things will increase the risks of substance abuse and suicide. Also, we found during research that there were poor mental health and well-being for children and parents, particularly women were the most affected, as the schools closed and they had to be the primary support for their children to take care of them from home. This pandemic also disproportionately affected race. So particularly communities of color, Black and Hispanics, essentially faced a lot of challenges to accessing healthcare, and they were more likely to be affected by job losses. And finally, we saw that many essential workers, people who worked on the front line, like healthcare workers, people in the education sector, or police officers, these people had a lot of risk contracting COVID-19 compared to other workers. And of course, due to this, they had more rates of anxiety and depression compared to others. So right now in the United States, we've had different areas with COVID-19, and it's really not localized specifically to a specific region, although in the past couple of months, it was in the southern part of the states. But right now, COVID-19 is still on the rise, mostly because here in the United States, we don't require masking at all. And the mandates for vaccines and testing are now gone. So since everything is open and there's no more restrictions, the cases of COVID-19 are still increasing. But luckily, a lot of people haven't gotten as sick from it than in the past. Right now, too, with COVID-19, we're also seeing other viral conditions that mimic the cold and flu-like symptoms like COVID-19, one of which is respiratory syncytial virus, RSV, which now we more commonly see in infants and children, and of course, influenza. So these two viruses are on the rise. And with influenza, in the past couple of years, with the pandemic, we had more people getting vaccinated for flu. This year, though, the rates dropped significantly because I think people are just, they feel normal and they don't want to get vaccinated anymore. So the rates of flu right now are at an all-time high as well. So with that background, I just wanted to tell you a little bit about how COVID-19 positively or negatively impacts the healthcare profession here in the United States. And we'll first start with how it led to a lot of healthcare shortages here in the medical system. So currently in the United States, it's very easy to get a healthcare job if you're looking for one. The number one reason is something called pandemic burnout, where a lot of healthcare workers during the pandemic, they were exhausted. It was very complicated patients that they took care of. So a lot of them left their jobs and quit. So as a result, there's a lot more openings for any type of medical patient contact worker. A lot of people quit just because there was a higher risk of exposure with COVID-19, and they were afraid at that time of contracting it. And of course, it was just more work demand where the patients were very complicated and sick. So they looked for other non-patient care jobs, sometimes even away from the healthcare sector. Also during this time, the governments, the hospitals, most medical systems required that if you were a healthcare worker, you had to get vaccinated for COVID-19. Some healthcare workers did not like that, which caused them to leave too. And finally, during the pandemic, particularly a lot of primary care areas closed. And once that reopened, it caused a lot of demands. So because there was a backlog to the number of people who could get in, there's, of course, more demand now for healthcare jobs. In terms of the pharmacist, right now, it's very, very easy to find a pharmacist job in the United States because there's just so many openings because of the demand. This is a timeline of what happened in pharmacy, but even before the pandemic in 2020, there was an increase in prescription volume and demand just because our population is aging, they're elderly, they're sicker. So they were getting a lot of prescriptions before. Then there was COVID-19 testing that was approved. And during this time, it was the pharmacists primarily that was able to do testing on a mass public scale. And after that, it became influenza season. So in addition to the testing that the pharmacists had to do, they had to vaccinate the public for influenza. And in December of 2021, that's when the COVID-19s were approved. So in addition to giving all different types of vaccines to both adults and pediatrics, the pharmacists had to do tests. They had to administer COVID-19 vaccine to the mass public, which was in high demand. So as a result, a lot of pharmacists were overworked, they were burnt out, and they left their jobs too. I wanted just to briefly talk about vaccine hesitancy, particularly among healthcare workers, because in this group, why we have vacancies, one of the reasons is because they just didn't want to be vaccinated with COVID-19 vaccine. The main reason for this is because they were scared of the side effects of COVID-19 vaccine and thought that it was too rushed. And they just didn't want to get it. So unfortunately, because of those fears, because of those false information, they left the healthcare sector with a very large void to fill. So we do have now good strategies on how to overcome staffing shortages if there is a pandemic. One of which is for contingency capacities where there's a need. Most hospitals and healthcare systems now will change the staffing schedules and have a reserve on board to make sure that you can rotate people into different positions to support patient care activities. Also, a lot more hospitals now are working closely within their region. So if one hospital doesn't have enough workers, they can send different workers to different hospitals to help care for the patients. And another thing that happened was every hospital had their own guideline. But if the worker was exposed to COVID-19 but didn't show symptoms, they only had to be on quarantine for 5 days and they could go back to work. In terms of crisis capacity for staffing shortages, we're not there yet, luckily. We haven't had a crisis need for healthcare workers yet in the United States, but some planning and discussions were involved in this, one of which was to shut down that area hospital and transfer both the patients and the available staff to another facility where they have adequate staffing. Also, there was discussion of having asymptomatic healthcare workers who are not fully vaccinated but aren't affected to continue working after their 14-day exposure. And if the shortages still continue, as a last resort, if they are positive for COVID-19 but don't have very severe symptoms, they could still work. But as I mentioned before, luckily, we're not at this point yet in the United States. And most of the staffing shortages, even though most hospitals had to deal with it in some way, shape, or form, they were able to manage it. In the primary care area with COVID-19, during the pandemic, about 55% of patients missed or canceled their healthcare appointments. And looking at this group, about half of them worry that they have healthcare issues that have gone unchecked. A lot of this was because, their healthcare facility closed at that time, or they were afraid of contracting COVID-19, or they just didn't have money for their healthcare appointments. But because of this, what we're seeing now for the first time is a lot of preventable diseases being developed. For example, cancer has to be pretty much the number one diagnosis that we're seeing right now, just because a lot of patients did not do preventative care, such as colonoscopies or mammograms during when the shutdowns occurred. So due to this missed appointments, about 30% of them missed a preventative care visit. 26% of them missed medical appointments. 8% of them missed prescriptions from a pharmacy. The same amount missed mental health appointments. 6% missed surgeries, and 3% didn't receive health care for a new disease state. So because of that, I think physicians now are more proactive in their care for patients who try to miss and reschedule their appointments, one of which is through telemedicine and telehealth, which I'll talk about later. And right now, in terms of the pipeline for healthcare applicants, what we're seeing is the increase in number of students who go into the medical schools. This is actually one of the benefits of what happened during the pandemic, but we're seeing a lot of diverse applicants, people who want to work in rural communities, people of minority backgrounds, and a lot of classes right now have moved to online so that education is more accessible. And there's more interest right now in other health-related professions, things like pharmacy, physician assistants, even public health, that we're seeing in order to fill these roles. So another impact of COVID-19 is the rise in vaccine hesitancy. So right now for COVID-19 vaccines, we have 3. Pfizer and Moderna are the most common ones that we use, but we also have Janssen. But Pfizer and Moderna, they're 2-dose series, and they're fully approved for COVID-19. One interesting thing that occurred during this time was that when the vaccines rolled out, children between 5 to 11 got emergency use to receive the vaccines. And during this time, pharmacists too were authorized to administer vaccines. This never happened before because in the federal law, pharmacists were only allowed to administer for adults 18 and over, but because there was such a shortage and emergency, federal law allowed them to administer pediatric vaccines for the first time. And right now, based on our guidelines for COVID-19, pretty much we're treating the vaccine like a influenza vaccine, where for the most part, we're recommending it on a yearly basis. And of course, a lot of these companies redevelop their vaccines to meet variants like Omicron. So in the future, I think it's going to be pretty much a booster shot that they get on a yearly basis. So here, when the vaccine mandates rolled out and people had to be vaccinated against COVID-19, there was a lot of resistance where people just didn't want to be vaccinated. The top 3 are Republicans, so there was a lot of political differences for this. People aged 30 to 49, and those from very rural, underserved communities. So with these disparities, you see a lot of pockets in the US population that were very, very vocal about not getting the vaccine. And some of the reasons included this. They were afraid of the side effects and the safety of the vaccine. They thought that within the couple of months that the vaccine was developed, it was developed too quickly. And as a result, they just wanted to wait, see that there was more testing on it so that they could get it later. With the politics, a lot of people just did not trust the government, particularly because there was a government mandate to do this. And they planned to use masks and other precautions instead. Other people just didn't like the vaccines and they thought that they were young and healthy, so they weren't at high risk for contracting it. And others just didn't think that it was a serious disease. So these are some of the reasons why patients were hesitant on getting it. So with vaccine hesitancy now, in the US, there's a lot of campaigns targeting against this by targeting 3 main areas. Convenience, by making the vaccines more accessible, available, and affordable. So in the US, the COVID-19 vaccines have been free. Complacency, where we try to educate the public about why vaccines are necessary and how it's a social norm. And finally, there's confidence. So confidence, I would say, is one of the areas that's hardest to overcome for vaccine hesitancy because it depends on the politics, the religion of a person, their peers, social media. So with this, it affects their trust for the vaccines. But a lot of campaigns in the US have really focused on leaders in the community, leaders that have instilled a lot of trust among these populations to come and talk about why it's important to get vaccinated. So here in the healthcare sector, they employ this method, it's called CASE, to approaching patients who are vaccine hesitant because it's very, very common. So with this clinician approach, it's a response to the vaccine hesitant patients that collaborates their awareness that they are hesitant. So the C stands for collaborate, where you acknowledge their concern and find some points that you can agree on. A is about me, where you describe your knowledge about vaccines. S is the science, where you have to describe what the information and scientific knowledge is. And then E for explain and advice, where you give your recommendation to the patient based on the scientific findings. So with this approach, it's one method to overcome vaccine hesitancy that's been very commonly used for COVID-19. So with another impact of COVID-19 to the profession, I would say one of the other benefits is that there's a lot of advances to telemedicine and technology. So telemedicine is the delivery of healthcare to healthcare professionals, where they're separated between distance between patient and provider. And it could be synchronous, where it's in real time, either on a laptop, a smartphone, a computer, or asynchronous, where it's in separate time points, where the information is responded and recorded at another time point. So examples of digital health, this could include things like mobile health apps, smartwatches, home oxygen monitoring systems, and exercise monitoring. These are used to interpret raw data. And in pharmacy, some examples of digital health that we use, we have dosing calculators, we have medication adherence apps, sensors on inhalers. And here in the picture, this is an internet-enabled blood glucose monitoring with smart technology insulin pumps. So there have been a lot of advances in digital health over the past couple of years. So there's a lot of advantages to patients for healthcare delivery if it's remote. It really improves access to healthcare, especially for elderly patients and patients living in rural areas. Particularly, I spoke about provider shortages. This remote healthcare delivery can really close health disparities by allowing patients to have preventable services. It also reduces the patient's costs with work, with traveling to the site, with childcare. And as a disadvantage, interestingly enough, about 20% of the US population doesn't have access to any digital technology. This includes things like laptops and smartphones, particularly among people who are older, people who live in very rural areas, if they have very low income, or if they don't speak English as a first language. Typically, these people are not very technology literate. So as a result, with telehealth, a lot of these patients are left out of it. On the provider side, there are benefits of using telemedicine because it decreases clinician burnout. And I think a lot of physicians use these processes to enhance healthcare. There's definitely more workflow efficiency during these processes because for patients who don't show up, with the science and the studies, it's less common in telehealth. And as a result, with less people not and there's a little bit more flexibility and more work-life balance that the provider can have. The disadvantages, though, is because there is a loss of face-to-face interaction between patient and provider. It sets up new challenges, particularly with people who are not familiar with telehealth, and a lot of providers had to make workflow changes and credentialing changes in order to set up the telehealth services in their practice. Among the practice site changes, we see changes to the laws that cause insurance companies to cover the costs of telehealth services, definitely a lot more commonly after the pandemic. So because there's more reimbursement for these services, practice sites have been able to create more innovative, more novel services to increase their revenues. Also, because the practice sites require less physical space in telehealth, this overall leads to less overhead costs. And as a result, they're able to broaden their service to more providers, which helps decrease the transfer to out-of-network. Despite the benefits, there are a lot of costs associated with setting up a telehealth service. And in addition to costs, they have to be cognizant of things that might be challenges, particularly security, because patients' private information transmitted on these virtual platforms, they have to maintain that. That's essential. And finally, among the payers, the benefit is that with these telehealth services, the studies really supported that these services really did reduce the cost of hospitalizations and emergency room visits, which overall decreased healthcare costs. Disadvantages, before the pandemic, as I mentioned, there were limited services that payers would cover for remote delivery. But now, after the pandemic, more and more insurance companies are using this. However, one downside, though, is pharmacists themselves who use telehealth services. A lot of insurance companies haven't fully reimbursed them yet. So that's something still that we're trying to advocate and work on. And finally, the last impact of COVID-19 is that among the pharmacies, there's something called more point of care testing that we're using and more clinical services that we're able to provide. So point of care testing, it involves performing a diagnostic test outside of a lab and produces a result to help manage patients with chronic diseases. Here we have something called CLIA. It stands for Clinical Laboratory Improvement Amendments. This is a law in which a lab has to perform testing on materials derived from the human body for the diagnosis, prevention, and treatment of a disease. However, for point of care testing, there's a waiver that you could do where you don't have to do all the standards and tests and rigorous procedures in order to get this clearance. So with these point of care tests, there's less restrictions that you can do to do testing compared to a lab. The benefit of this is that it provides results in a very short time period. And this is really helpful because during a counter, the pharmacist can see the diagnosis with the lab result and treat the patients then and there. The limitation, though, is that some of these tests do have false negatives and false positives. So it's recommended that for these tests, you try to collect these specimens early in illness as possible, follow the manufacturer's instructions, and confirm again with another test. However, point of care testing now, especially after the pandemic, has been on the rise, and it's actually expected to even exceed the delivery of immunizations as a driver for revenue here in community pharmacies. So right now, these are the common types of tests that pharmacists are able to offer the public, but they can do point of care testing for things like the flu, hepatitis C, HIV, streptococcus, INR, A1C, lipid tests, thyroid tests. Typically, though, the most common tests that they do are the streptococcus and influenza tests. And in the studies for pharmacists who are able to provide these tests to the public as point of care, in the data, it helps increase access to services, but it also reduces inappropriate antibiotic usage. So there's been a lot of positive outcomes for pharmacists who use this. Of course, point of care testing for COVID-19 also allowed pharmacists to expand their services. Nowadays, after the pandemic, it's mostly only in the pharmacies that patients right now are able to get a point of care test for COVID-19. No other healthcare facility offers it anymore. So that's been another big responsibility of how the pharmacy profession has changed and developed because of the pandemic. And in terms of models for point of care testing, in the past, it was similar to the model on the left, where if a pharmacy wanted to do point of care testing, they had to work with a lab where they collected the sample and they sent it to the lab for the lab to analyze. So as a result, there was always a delay in getting the specimen to be analyzed. So, but with that type of model, there was always payment for their services because the lab was able to get reimbursed. Now we kind of follow the second model on your right, the point of care model. So now more and more pharmacies are applying for this CLIA waiver. And as a result, they're able to perform the point of care testing themselves, where they're able to collect the specimen, analyze the specimen, and then tell the patients face to face what the results are right away. So with this, there still are a lot of challenges for reimbursement. It really depends on the state in which you're located in. But this is more so the model now for community pharmacy. And a lot of pharmacists now enter into agreements with doctors so that they can get their patients into the pharmacy to do these services. So it's a win-win for both the pharmacist and the physician. And finally, a lot of pharmacists too nowadays have been approved by the state to treat minor conditions, things like Florida, Kentucky to Washington. Every single state has different laws about how much a pharmacist, depending on the states, the pharmacist can see patients for these minor conditions, things like allergies, insect bites, cough and cold. They're able to diagnose the patients, and they're able to offer them medical advice, even with medications for these disease states. And a lot of the pharmacists are able to bill for their services. So this is another advancement of clinical pharmacy here because of the pandemic. So that was a very quick overview about all the changes in the healthcare sector, particularly in the pharmacy world, about how COVID-19 affected us and what the future holds. I want to thank you for your attention, and I'll take questions that you have at this time.
Thank you, Dr. Yan, for sharing the evolution of healthcare in the United States post-pandemic. Even in India, the graph of medical students and pharmacist intake rised post-pandemic. Now, may I please request our renowned scientist, Honorable T.R. Bhardwaj sir, to begin the Q&A session. Over to Bhardwaj sir.
Very good morning and good day for the others who are from outside India. Dr. Yan, I would like to congratulate you for enlightening the participants with respect to the post-pandemic era and the healthcare provided by the USAC. It's again matter of pride that all our fellow pharmacists, they are rendering their best services to the public, and their services have also been recognized by the society. I want to have some kind of clarification with respect to, say, in as you said that in USA, during pandemic and post-pandemic, there must be some more numbers of the patients suffering from psychosis or maybe depressions or those kind of things, which are being, again, it's a matter of, again, being treated by the doctors. But is there some organizations, voluntary organizations specifically, who are simultaneously helping the poor students poor patients who cannot have access to those kind of technologies or other help they are requiring during this phase? In India, we have number of organizations, NGOs, who are helping the poor persons or those who are having not access to or they are not affordable, they cannot afford the treatment. So such kind of organizations are there, voluntary organizations are there in USA, or it's all government or the federal responsibility? Please.
Yeah, that's a great question. During the pandemic, one of the good things that happened was the government covered all types of medical services for no cost for anybody with a COVID-19 diagnosis and complication. So if they had things like psychosis with COVID-19, that was treated for free. Now, if they just had mental health issues alone, that was not covered by the government. It was more covered by our community organizations. So one of the things too that occurred is that there's a lot of nonprofit organizations now that opened up because there was so much need for access to medical care. We're seeing a lot more free medical clinics now. I work in one, for example, where we provide our services to patients free of charge for most primary care things. But there's other organizations that provide free dental care and so on. So we're seeing a lot more of that on the rise.
Counseling of the patients also?
Yes, counseling is definitely a need. So in terms of mental health, we have both psychiatrists, we have counselors, but we also have community health workers. That's kind of a newer designation nowadays. Community health care workers, they don't really have a strong healthcare backgrounds. They're more like lay people, but they're educated on a specific disease state, and they go around in the community, usually door to door, for these patients to try to help them with things like mental health or other disease states. So that one too is also supported both by the government and the community agencies.
Thank you very much for your. Over to Dr. Shalini.
Yes, sir. Now I request Dr. Ravinesh Mishra, sir.
Thank you, Dr. Ain, for delivering such a wonderful talk with respect to COVID-19. That is our present cause of concern around the world. So there is a one question from my side, like very frequent vaccination of this COVID-19 is going to affect in near futures the human health?
Yes. So, in terms of the long-term impact of COVID-19 and the vaccine, you mean? I think it's still being studied. They've pretty much 80% of the population here has been vaccinated. We are seeing, particularly with younger patients, changes in menstrual cycles because of the COVID-19 vaccine, but that hasn't led to any other complications. Most of the side effects are very mild, but for long-term complications, it's still being monitored. But as far as our government organizations, they've approved the vaccines for full use. Right now it's actually for people 5 and above. So with those vaccines, it's still being studied, but I don't think we're seeing any major consequences so far.
Okay, thank you. And thank you for supporting us.
Thank you. Thank you so much for inviting me.
So over to Madam Salini.
Thank you, sir. Participants can also raise their hand to ask any question. Participants. You can also drop your message in chat box. Okay. Thank you, Dr. Yen, for sparing a good time for us.
Thank you.
I hope we will see again.
Definitely. Thank you, everyone.
Thank you, ma'am. Now it's time to welcome our next keynote speaker, Dr. Seen Vasaitis. Dr. Seen, are you with us? Participants, Dr. Seen is going to start within 2 minutes. Hello, Ma'am Shivani. Shivani,
Yes,
ma'am.
ma'am. Yes,
There is
ma'am.
one question. There is one question from Bhartendu, sir. Can you please let him in?
Okay, ma'am. Done.
Dr. Yen, are you with us?
Yes. He says
Okay.
that he cannot. He's waiting to join.
Okay, Dr. Yen, there is one more question from one of our participants.
Thank you, Dr. Shalini. A very good morning, Dr. Yen. This is Bhartendu Sharma, Associate Professor from Baddi University. I have a question about that. In India, what we have observed that during COVID-19 and after COVID-19 pandemic, most of the people are suffering from vitamin B12 and vitamin D deficiency. That leads to major depression, stress because of the hormone released cortisol. So that vitamin B12 deficiency is leading to too much depression, and you have all mentioned in your presentation about the depression and anxiety. So instead of giving this vaccination before giving vaccination, can in US you are also the government is also using this vitamin B12 shots and vitamin D shots?
Typically, for the patients that we have for mental health, they do a full workup for labs, and that includes things like a metabolic panel, thyroid tests, and other vitamin levels. But we would only replete the B12 labs if the level came back low. For patients suffering from mental health, we don't automatically give them B12 shots if their levels are normal. But that's a good idea.
In India, what we have seen, and most of the patients, they are basically suffering from vitamin B12 deficiency, and this leads to other diseases. So it's better to give vitamin B12 shots and vitamin D shots so that the other diseases cannot generate because of this oxidative stress.
I think in the US, vitamin D deficiency is more common. So we're giving supplements for that. Not so much B, though. That more so depends on the lab levels for that.
B12 is there. B12 cases are more because of this COVID-19. In 2020, there are more cases arises in India due to B12 deficiency.
That's interesting. Yeah, that's a good point. I think nowadays they just screen for the patients based on the lab, but we don't preemptively, prophylactically administer that to all the patients. So that's interesting what you're doing in India.
Thank you.
Thank you.
Thank you so much. Thank you, Shalini ma'am.
Thank you, sir. Thank you, Dr. Yen. Shivani, ma'am, Dr. Seen is waiting outside. Can you please let him in?
Okay, ma'am.
Can you hear me? Can you hear me? Hello.
Hello, Dr. Seen.
Hi, how are
Good
you?
morning. I'm fine. Good morning.
Yes, good morning. Good morning.
Can we start?
Give me 1 second. I just need to pull up the slides here. Just having a little trouble with the
Sure, sir.
computers. Give me 1 second.
Yeah.
All right, then to share. Let's see. Over here. All right, is this? This one? Okay, how is that? Can you see?
Yes, it's visible.
Okay. All right. Great. Okay, let me turn the camera on for a minute
So
here.
participants, now it's time to welcome our next keynote speaker, Professor Seen Vasaitis. And I'm taking a moment to introduce Professor Seen Vasaitis. He is Interim Dean of the School of Pharmacy and Health Professions in 2021. He joined the UMES School of Pharmacy as a founding faculty member in 2010 and was Assistant Dean for Student Affairs in the School of Pharmacy from 2017 to 21. Dr. Vasaitis completed his doctoral work in pharmacology and experimental therapeutics at the University of Maryland School of Medicine in 2007. He holds a master's degree in exercise and health science from Miami University and bachelor's in biology from the University of Maryland, Eastern Shore. Prior to this appointment at the UMES, he completed 2 research fellowships. The first was in cancer drug discovery with the world-renowned Dr. Angela and Dr. Vincent, which continued his work in the development of novel inhibitors of androgen action for the treatment of prostate cancer. His second fellowship involved clinical and translational research in the geriatric research, education and clinical center at the Baltimore Veteran Affairs Medical Center, investigating the mechanism by which exercise, vitamin D, and complementary therapeutics affect metabolic function and glucose homeostasis. Dr. Vasaitis' research goals follow the overarching concept of integrating Western approaches to medicine and pharmacological therapy with evidence based complementary medicine to further a holistic approach to disease treatment. I would request Dr. Seen Vasaitis to please start the presentation. Over to Professor Seen.
All right, welcome. Thank you so much for the introduction. So I'm Sean Vasaitis. I'm going to just give a presentation on the potential for using tai chi for essential tremor, so for the movement disorder essential tremor. We did do a short exploratory study with just a few participants to see, how feasible this would be and what some of the challenges were in doing this. So I'll present a little bit of that at the end, but then just kind of general overview for central tremor and tai chi and how that might fit together. All right, so let's see. Okay, so starting out with essential tremor. So essential tremor, that is the most prevalent tremor-related disorder. The prevalence does increase with age. So of course, with increased life expectancy, we'd expect to see more cases of this, but it's more prevalent than Parkinson's. People don't usually think about essential tremor as much, and you don't hear about, at least in the USA, you don't hear about it as much as you do with things like Parkinson's, but it is much more common. The other thing is that essential tremor used to be thought of as a benign disorder that was just characterized by this one tremor. And more recently, people have began to understand that patients with essential tremor can have other motor and non-motor symptoms as well. So you might see things like impairments with gait and balance. You may also see issues where the patients have trouble sleeping. Hearing loss has been associated with it. There are psychiatric changes that are associated with it. Also, mood changes as well. And again, it is considered to be progressive now, so that it does tend to get worse as people get older. Now, this central tremor itself, it's going to be characterized as an isolated action tremor and present in bilateral upper extremities for at least 3 years. They typically have it in the hands. So if you see my video here, I actually have a central tremor. My hand does shake if I move it into certain postures, and just on normally they'll shake. So usually you'll see it there, but some people will also have a tremor in the voice. You might see it with the neck and head, so the head may move around some. Also the lower limbs, the legs may shake, for instance, as well. And one of the other things about it, a lot of times people will not seek treatment for a central tremor because they might think, oh, it's just a thing of getting older, or, that's just a natural thing. Or especially when they're younger, people might get, embarrassed by it. They might get teased by it, but they might not seek out any help for it. All right. There are also, as I mentioned, gait impairments and balance impairments as well. Typically, they're mild, but in some patients, it can be quite severe. And in some cases as well, they can be associated with increased risk for falling, also reduced confidence as far as for falling as well. And you can see these things in tests like the tandem gait test, where you'll see an increased number of missteps with patients that have a central tremor. All right, so then some of the symptoms and the consequences of having a central tremor, one thing would be quality of life. So the tremor can interfere with eating and drinking. I have known many people that when they pick up a fork, if they have food on it, the food will just come off the fork. Women, sometimes they're putting earrings in, they won't be able to put the back clips on because the hands are shaking too much and things like that. So shaving, putting on makeup, writing can be a big issue. So one of the tests that they use also, they'll do circles tests, spiral tests, and you can see the tremor within the spiral. So writing can become a problem. And thinking about it in today's age, when you're using your cell phone, that can be an issue as well for doing text messages and things like that. You also see social withdrawal. Sometimes people go into early retirement because of it. The hobbies that people have can be limited. They might do less sports activities as well. They might have incoordination, and this can lead to depression and anxiety, of course. And then sometimes people just don't want to come out. So even for having this study, some of the people that we spoke with, they were just too embarrassed about it to come out to participate. Now, the symptoms, they typically occur in the hands first. That's not always the case. Sometimes people will get this when they are quite young, and sometimes they get it when they're older. It's more common for people to get it when they're older. And the symptoms can get worse with movement. Stress can make it worse, obviously. Fatigue, caffeine can make it worse. Changes in temperature and sleep deprivation, that can also make it worse. As far as treatments for essential tremor, there are beta blockers that people use as one of the main treatments. There's some anticonvulsants. There are also some deep brain stimulation and some guided ultrasound that people can use as well. For the things that we looked at, since we were looking at tai chi being an alternative therapeutic, we weren't looking so much at the changes in the brain and things like that, or the effects of the medications along with it at this point, because again, this was just kind of an exploratory thing that we're doing here. All right, so following up with that then, so I talked about tai chi, I talked about essential tremor. So what is tai chi chuan or tai chi? That is going to be a combination of Chinese medicine principles with martial arts that allow practitioners to train in a healthy manner. So you'll see some explanations of it. It's a gentle art where people move slowly. Some people will say it's moving meditation or similar to Qigong. Not as similar to yoga in the fact that you're continuously moving through each of the postures. So it's estimated to be one of the most widely practiced forms of exercise in the world. So you have an estimate from 85 to 250 million people that practice this. There are various styles of it. There's the Chin style. So looking at the family versions of it anyway, there are a bunch of different branches that came off of that. But as far as the styles that are typically seen, the older one would be the Chin style. And then you have the Yang style, which branched off of Chin style. Also several others, Wu, Wu Hao, and Sun style, which also branched out from Chin. The Yang style is going to be the most popular one. So when you see people on television doing Tai Chi, or if you see people in the park or something like that, typically you're seeing Yang style. Now, the issue with this, when you want to do a study and when you're looking at studies that are based on Tai Chi, there can be a lot of differences based on what style people are practicing and what the teacher's approach to it is, because it's not necessarily standardized, and you don't have an accrediting agency or something like that that's going to say that it's, you know, good Tai Chi or it follows all the principles. So when you're looking at the studies, it's kind of hard to compare because people may do different things. They might follow different styles. The other thing is that the traditional training may be different than the more mild type training that you might see with a class where you have 5 weeks and you're certified and then you can go teach or something like that. For the more traditional styles, it would take quite a long time to learn it very well, which could be something that's prohibitive for people that want to use this as some sort of treatment. So the adherence to it or the participation in it may be a little bit less, or could be a lot less, because of the intensity and things that you have to put into it when you're practicing a more traditional way. All right, so typically what people might see would be something like this when they think of Tai Chi. They think that, it's just it's older people that are moving very slowly and just doing gentle, graceful movements. And that's pretty much what most people consider about it. However, again, for the traditional training, it can be much more intense than the general public perception that you would see. And there are a lot of different factors that go into it. So I'll talk about some of the different aspects of Tai Chi as well. But notice here in the center of this picture where you have the circle being the yin yang symbol, and you have what are supposed to be opposites and then moving into each other. So you could have hard versus soft, for instance, and how those things interchange and are intertwined with each other and moving from one to the next. And when you think about that, a lot of people think about this with balance, all right, balance between opposing forces. So that aspect of Tai Chi, it should be interwoven into the movements, into the practice of it. But as well, when people say Tai Chi is always slow and gentle, that's not necessarily true either. So if you have the soft aspect, and having the hard aspect can be there as well. And just to kind of show you, if you're not familiar with what this might look like, here is a practitioner doing a particular style. And here you notice everything is slow. There's shifting of weight from one leg to the other, relaxation in each part, steady stances, smooth, controlled movement. The slowness will help to build that control and understand what happens within the body as you move from place to place. Notice there the weight is on one leg, so the weight is mostly to one side, the other leg is more empty. And those kind of things help with balance. And then also notice there's a particular structure. The back is fairly straight. The body is upright. And that follows through the weight shifting as well. So this is where the movements are done more slowly. But as I mentioned, if you have the slower, you can also have the faster. So looking at the same practitioner, this is also Tai Chi on the other side. So most people usually think of just the slow part, but you can have that fast part. But in the fast part, there should be a loosening and relaxation that is built in that comes before the explosive movements. So you're learning to transition between that soft, relaxed state instantly into the fast, explosive state, and then back to the soft state. Now, of course, if you're looking at older patients, they probably might not be able to do a lot of those things. So it can still be practiced either way. The important part is to understand the principles, understand how the body relaxes, how the structure is built, and the connections between different parts of the body. So the same practitioner is the same person in both of those videos. In the video on the left side here, he's probably around 70 years old or so, and he's still able to make a lot of the movements. So the other thing is that starting earlier is going to be more helpful because you have more time to build up the skills and to very much understand how you can control your body. With essential tremor, a lot of times people won't come to get help until they're older and until things get worse. So that's one of the other kind of difficult factors to deal with. So going back to the Tai Chi though, some of the things that we were exploring, we looked to incorporate some of those principles and see how they may help someone that has the symptoms that Tai Chi is known to help. All right, so things like balance. Tai Chi is well known to help people regain balance, increasing strength, flexibility, increasing mobility, things like that. Now, some of the, again, principles that you would look for would be the structure and alignment of the body. So keeping the back straight, being careful for how the hips turn, how the shoulders and the hips are aligned, that you're not too far forward, which can cause balance to be broken going forward. Making sure that the waist and hips aren't pushed inwards. They're not contradictory or out of alignment so that your feet can come up on either side and you can lose balance. It's a little bit difficult to explain without showing you. Also, there's a principle of mental quietness. So the practitioner should be learning to calm the mind and calm the body. And a large part of it is learning that looseness, relaxation, and calming. And the idea here, of course, is that if you calm the mind, you reduce the stress, you reduce the anxiety, and that hopefully would be able to affect the severity of the tremor when it is active. So when I talk about relaxation also, I can give you an example. So if you're sitting there, if you want to try this, if you take your arm and you twist your elbow forward. So if you look at me from the side, if I'm pushing this forward, if you do that, then what you should feel, and if you hold it there, you'll feel that your shoulder should feel quite tense. You're holding your arm up and your shoulder's tense. But if you take that same posture and you drop your elbow like this, then in this case, your shoulder is relaxed and loose. Here it's tense, here it's loose. When it's loose, you're still doing work. You're still holding your arm up. So there's still work being done. But that looseness is going to prevent the tension, if you go too far, the stress in the arm. So you're not necessarily relaxed in a sense of you're just collapsed and everything is, oh, this is so wonderful, I'm just so relaxed. It's more of you're doing work, you're holding things, you're holding a posture, but you have to make sure the joints are loose, that the mind is calm, and you're not creating blockages by being too tense or stiff anywhere in the body. What happens with the slow movements? The slow movements will help the person to understand where there's tension in the body, feel everything as they move from one piece to the next, and follow the next principle of continuity of movement, meaning that you want to be aware of each place where the body is moving as that movement contributes to the next movement. So for instance, if I'm moving my arm and let me take this. So if I'm moving my arm and my shoulder is here, if I turn my body first, then my shoulder moves, then the bicep moves, then to the elbow, then partway down, then wrist, then hand. And you want to be able to feel each part of the movement. So usually when people move, they just think hand, reach, grab, but through the slow movements and the Tai Chi practice of starting with the torso, with the dantian, with the area around the navel first, and transitioning and feeling the movement from your body up the back, out through the back, through the shoulder, and down the arm to each point, you become aware of what's happening inside the body. So the point would be that you want to really become aware and have precise control in the body and understand what's happening as you make each movement. So one of the things we say is either you control your body or your body controls you. And it's that same type of idea. How much can you control? How fine can you tune your movements so that you can eventually try to feel what's happening in the tremor or with the balance or whatever it is and compensate for it? All right. So one of the other things, there's weight transfer, where you practice slowly moving weight from one side of the body to the other. And when you do that, again, you're very conscious of what's happening, what the body structure is like, and where you start to feel you go into a place of imbalance because you're moving slowly. You want to be able to correct that break in the structure so that you become very aware of when your structure is broken and when it's possible to, or when it's more likely to lose balance because of that broken structure. So understanding all of those things, the idea would be that that would help to, improve things like balance in a condition like essential tremor. And also understanding the body perhaps can work to affect the tremor itself. So looking at Tai Chi again, so some of the health aspects, you have things like reducing stress, you have reduced cortisol levels, that salivary cortisol concentration has been decreased. There are studies that show that. Also helping with blood pressure, body awareness, increasing strength, increasing flexibility, and increasing mobility. There also can be a social aspect as well. And that's another thing that can be very helpful for someone with essential tremor if they go out and if they're particularly with a group that understands that and provides that extra mental and emotional support that goes along with them. All right, so the evidence for tai chi affecting essential tremor that's anecdotal. I've worked with essential tremor groups. Like I mentioned, I have essential tremor myself, and that's where the idea came from for me, because I was a lot worse in my 20s. And, you know, people would tease, hey, another shaky guy, et cetera, et cetera. But then as I practiced this for a number of years, I noticed that it got a lot better. So that was where my my initiative to do this kind of thing came from. And then it so happened that studies for tai chi in Parkinson's disease began to come out as well. So the evidence to date does support a potential benefit for tai chi in improving motor function, improving depression and quality of life in individuals with Parkinson's disease. It did validate the need for additional large-scale trials. So there were a number of trials. There were some analyses that came out as well, reviews that did show the improved motor function, and especially relative to other control groups. So those things have been pretty well shown. And also clinical measures of balance, fall reduction, timed up and go tests, where you measure someone getting up, walking, coming back and sitting down. Those have been, you've seen improvements in there, also improvements in fall risk and improvements in depression that have gone along with Parkinson's. So when you interpret that also, you do have to consider a lot of things. For instance, when I mentioned you have the different styles of tai chi, you have different kinds of teachers of it, and then there are some that may not be as familiar with the principles for more traditional type practice versus more modern type practices where people will just teach choreography. And one of the main things that we wanted to see with what we were doing is looking at the principles rather than just choreography. Because anybody can go in and just do a routine where you wave your arms around and things like that, but that's not really going to be traditional tai chi. Right? It can help people by having them move, because anytime you move around is good, but we wanted to really look at some of the differences. So some of the other things that can cause conflicting results, the length of the intervention. This is something that people need to take time to learn. And that's one of the things that I found working with people after we had done this short study, this exploration. The approach to the patient is very important. And one of the expectations that needs to be set is that when you're doing this, you are learning a skill. This is a learned therapy. It's not a pill. So it does take time, just like if you're trying to learn to play the piano. You're not going to take piano once a week for an hour and and play Mozart in 5 weeks. So you need to practice at home. You need to really take the time to develop that skill. And I found that once people understand that, then it changes their perception, and it also increases, in my experience, their motivation to stick with it and to work on actually learning the skill to be able to take advantage of it. Otherwise, they might expect, okay, I've done this choreography for so many weeks and I haven't seen anything, and they might leave the studies. So that's one of the other things that we found from it. Okay. So what we did for our study, again, it was just an exploratory study to try to understand the theoretical basis for conducting future studies and to understand some of the implementation issues. What we did, we selected participants with a previous diagnosis of essential tremor. They were over 18 and primarily recruited from an essential tremor support group that we work with called the HopeNet. We also had additional presentations at regional symposiums. I also do some different seminars for Parkinson's patients as well. So we recruited people from different places. Exclusion criteria were people with Parkinson's, with end-stage cancer, or other conditions or disabilities that would prevent the person from safely participating. Multiple sclerosis was another one that we used as exclusion as well. When we brought the participants in, we did different questionnaires looking at demographic variables. We looked at medications taken. We also looked at the duration of symptoms, the age of tremor onset, if there was a family history of tremor. We asked questions, kind of open-ended general questions as well, about for the patients to tell us about their essential tremor, to talk about their balance, their memory, what their biggest challenges are related to essential tremor, if they feel self-conscious, what their current exercise routine is, if they practice meditation or other stress reduction activities, if they have issues with anxiety or falling asleep as well. The average age of the patient was 77. So it was an older group. There were 18 to start, and the age of onset was 42, although this did vary. So some of the at least one of the participants noticed the tremor at age 7, and another one had an age of 75. So there was quite a big range when you look at it. And 6 were male, 12 were female. This was to start. Family history of essential tremor. 6 of them had a family history, and only 4 were on medication for essential tremor. But that's the other thing. The medications, they don't really work that well for most patients. So they work for around 50% of patients. We were also interested in people with more mild to moderate forms of essential tremor, which is what we had in our group as well. But the medications will usually help maybe 50%, and then quite a large percentage, maybe depending on the study you're looking at, maybe 30% or so might drop the medication also over time. So they're not very good options for the patients as it is. So what we did, we had 1-hour classes, and we held them once per week for 22 weeks. And we also encouraged the patients to practice at home for 1 hour per week. And again, the main goal was to determine what aspects of tai-chi might be useful for this group for improved mobility and function. And then we also did just some examinations of balance, just as a secondary goal since we had them there. But the number was so small that, we don't really want to draw conclusions from that, but just kind of wanted to see how the before and afters would look like for it. And so what we saw, 8 of the participants dropped out of the study by the midpoint. And again, this was before we went to setting that expectation that this is a skill, a learned skill that would take a while for someone to develop results with it from. The 10 remaining participants, they had a lot of great insights and a lot of good information we found out regarding the things that would be helpful and that we should move forward with in future study. So one of the things, I didn't really put this stuff on the slide because it's a little bit difficult to explain, but a little bit easier to see since we are at the kind of presentation where you can see me. So that's the very good benefit of this. So the structural changes that Tai Chi helps a person to understand could lead to increased function. So for instance, as I mentioned earlier, if the tremor is active, so it's an action tremor, especially if it's an intention tremor, and a person is moving forward, for instance, and if the tremor is in the hand, changes to the tremor or a reduction in it, some of our participants were able to reduce it by changing the body structure around it. So for instance, if I'm moving this way and there's a tremor, by going through the Tai Chi principle of relaxing here and bringing this part down, and using the body as a support for the arm. So instead of using the muscles in the arm so much, you're using the body structure to help lift the arm. So not lifting this way, I'm letting that relax, letting gravity pull down, and using that principle to reduce the amount of stress that I'm using to reach for something. And by practicing things like that and understanding how to relax, and by being relaxed, still be able to hold structure, the participants were able to increase function and reduce tremor. So for instance, also for holding a fork, if you're holding it a certain way, again, if you're stressing that arm or activating the muscles, it can increase the severity of the tremor. Whereas when they learn to relax and let gravity pull down and follow the tai chi principle, they were able to have to keep things on the utensils as they move. So those were the types of things as far as the tremor itself. And again, since it's such a small sample, we were just trying to find out what might be the areas that we want to use and to focus on for a larger study. The other things that we saw, we did see increases in the single leg stand. So the average before we started was about 4 to 5 seconds that the people could stand on one leg. And then at the end of the study, almost all of them, 7 out of 10, were able to stand for at least 10 seconds. I had one of them that was around 6 to 7 seconds when he started, and was able to stand on one leg for 60 seconds at the end without touching anything, just standing on his own in one leg. The tandem gait test, where you walk and you put your foot in front of the other one, heel to toe. A lot of the participants had a lot of errors in their steps when they started, and we did see a reduction in the number of errors in stepping. So stepping off the line being counted as an error. We also saw a 14% reduction in an 8-foot up and go tests in the time for them to stand up, walk 8 feet, and come back. Also, a 4-square step test where you have a cross on the ground, basically, and the participants step from one square to the other in a pattern and step over the line in a pattern. We had a 12% reduction in time for the participants to do that. For side-by-side standing, where the participants stand with both feet together and just stand there, actually all of them were able to do that just fine. So we didn't see any problems with that test from the beginning. And the same with the semi-tandem stand, where the 2 feet are closer with the foot part way up past the heel and not just heel to toe. They were fine with that as well. We did a 4-meter walk test with the usual gait speed. We saw an average of about 10% to 25% increase in the speed for them, or the time. I guess I should say decrease in the time they took them to take that 4-meter walk test. So the gait speed was increased as well. So quite a few things that would imply that this could be something that's effective for balance with people that have essential tremor, which would be similar to people with Parkinson's, although the type of tremor tends to be different. So for essential tremor, we're looking at that action tremor rather than resting tremor, at least in the group that we were looking at. Other than that, we did find that a lot of it is going to be dependent on, as I said before, how the teacher is teaching. And there were some balance issues to start with in being able to get people to do the tai chi postures, because some of them, the balance wasn't good, so they couldn't really do it that well in the front. So we had, of course, to use some modifications. They might have had to touch things, or if they had a partner with them, their partner could hold their arm or whatever to help them keep balance as they went through it. But overall, we did see that this should be looked at further, and especially looked at in terms of trying to bring in that meditative part, bring in the relaxation part, and make sure that people are having that calmness, feeling gravity pulling them down, and feeling the support of the structure to support the limbs so that they can control the movement in a finer way to potentially reduce the effect of having those tremors, or at least reduce the severity of it when they're doing basic motor tasks. Some of the other challenges that we mentioned, of course, the dropout rate was not good, and the age and overall health of participants can be a bit tricky because, again, people don't usually come with this until they're older. So it would be much better if you could start somebody in their 30s or 40s, build up the leg strength, build up the body control. And my thought or hope would be that that could possibly reduce the progression, or at least slow it down. I don't know if that's for sure. This is just a speculation, something that should be tested, or at least slow down the loss of functional ability, because people would have the understanding of the compensatory mechanisms before or as they go into a worse state with the tremor itself. Scalability might be an instance because, scalability might be a bit of an issue because, again, this is a learned skill. So how many people start taking piano and then they drop it? You have the same kind of thing. If you really want to be good at it and really understand it, it does take quite a bit of work to actually do Tai Chi well, as opposed to just following choreography somewhere. We did actually do some quality of life studies as well. So there's a QUEST study, which is a quality of life in essential tremor survey sheet. I don't have the data for that right now, so I'm not going to present that. But we did look at quality of life as well. ABC 16, a number of different other surveys were done. Okay, and since I started a little bit late, it's 9:53, so I'll go ahead and stop there. Do you have any questions?
Thank you, Professor Seen, for remembrance of Bruce Lee, I would say. And that is amazing and interesting session. Although Tai Chi is quite tough, but you mesmerized all of us. And the initial movement exercise, although it is tough, but the people can learn the initial movement exercise of Tai Chi.
Yeah.
And now moving forward, I may please request our panelist, Professor Bhardwaj sir, T.R. Bhardwaj sir, to begin the Q&A session. Over to Bhardwaj sir.
Good day, Dr. Sean.
Thank you. Good day to you as well.
Yeah, it was very enlightening talk, specifically with respect to the Tai Chi, which you have described. As you said that the Tai Chi can be very beneficial, specifically with respect to the person suffering from the Parkinsonism. Is it also helpful or of benefit for the person who are suffering from maybe knee joints? In India, we see we have a large number of persons, people, maybe around 50 or so. They have knee joint pains, severe pains, unbearable, including arthritis or maybe gout also. So in those cases also, I think if this kind of exercise or the Tai Chi is practiced, then it may delayed or it may be treatment for those persons. What's your opinion about that?
Yes. So I'll say yes, but I'm going to put a little star beside it, and I'll explain the star after. So yes, it can be helpful because this will actually make the legs very strong. And for people that practice seriously, their legs will be really big because the muscles are going to really they're going to have to absorb as you sit into those.
What about the joints?
So
what about the joint?
Yeah. All right. So this is where it starts. So it is known to be good for arthritis, for instance. But the thing is, from my opinion, having done this for many years, the teacher has to pay attention very closely to the way that the person is moving, because if you're doing this properly, you can put a lot of weight into the joints. And if someone is shifting their weight, they should shift their weight so that the knee bends in a natural direction. But almost all beginners will start out and they'll torque the knee a bit as they're shifting. So if the instructor is paying attention, they'll correct them. And a good instructor should always put hands-on corrections, straighten people out, and make sure that they're not, especially in the beginning, doing things that are going to damage their joints. Because if you're doing it properly, like I said, you do put a lot of pressure through the body. But if your alignment is good, then it will be very good for the joints, very good for the knees and everything else. But I shouldn't say everything else, but very good for it. But you do have to have the right person, and you have to tell them if they do feel any pain in the knee, not to work through it, but to stop, maybe move it a little bit to kind of loosen it up again and to take their time with it.
Proper movement is very much required and beneficial. And second, of course, this is not pertaining to the tai chi, but as is told by Shalini, madam, that you did your research in the area of maybe prostate cancer or so.
Yes.
If you feel that, I would like to know what were your findings, just in short, maybe if you so, because I'm very much anxious to know about your this thing. You see, the BPH, benign prostate hyperplasia, or 5-alpha reductase, if you have worked in that area.
So mine
is it okay? Or
we were mostly looking at inhibitors of androgen action for prostate cancer. So we were designing therapeutics that would have multiple mechanisms to attack it. So they would downregulate androgen receptors. They would block the ligand from binding to the receptor. Also prevent the synthesis by blocking the 17 hydroxylase, CYP17, and reducing the amount of translocation of the receptor into the nucleus. So we had some very good compounds. One of them did go to clinical trials. It's still in a different clinical trial now. But that was where my area was mostly. And most of that I did quite a while back. So that was
in
really
fact, I would like to have, I would like to have, you see, publications or the outcome of that from you. I'll contact you in that case also. See, since we are working in the area of 5-alpha reductase inhibitors also, which block the conversion of testosterone to dihydrotestosterone, which is responsible for these things. Like finasteride, which was used earlier, and now I think dutasteroid or those kind of things are being. Thank you very much. Thanks a lot.
Yeah, thank you.
Madam Shalini, over to you.
Thank you, sir. Now I request Sushma ma'am to please ask questions. Over to Sushma ma'am.
Hello, Sian. Wonderful listening to you. I have been doing Tai Chi for many years.
Great.
But here in India, we don't have the teachers. So the teacher is the YouTube.
Oh, okay.
I have been doing the Chi Kwang, those different steps which they teach. I just love the small, very smooth movements, and every joint is moved in it. But I'm not sure, well, at this age, like above 60, now definitely the balance is going bad, because number of tripping, now falling, has increased even for me, even after doing all these exercises. So what therapeutic videos or some teaching could you tell, like to stabilize the body? In spite of doing Tai Chi and all, I don't think my balance is so good. You suggest something? No Parkinson or any disease yet, but the sciatica is there, and the gait has now really become bad.
Okay. All right. So for that, one of the things, again, the key to it, I'm going to stand up here. So I don't know if you'll be able to see
Yeah.
All right. So the key really that you might not get from most videos is that one, the points 1, 2, 3, and 4, they need to be in alignment. So for instance, if this point is sideways, if you could see my foot, my right foot is actually turning like this as this pushes over. The same thing, if these are too far forward, then eventually your heels will come up. If this is too far back, if it's too far back, then you can fall forward. If these points are too far over, you can fall that way. If it's too far forward, you can fall forward or fall backwards. So the alignment between those points is very important. The other thing is that as you're practicing, you have to make sure that the feeling, if I'm standing with both of my feet on the ground here and I feel comfortable and I feel like I'm stable, if I shift my weight to one side and I bring my other foot in, this should feel exactly, I have my foot on my toe right now, the way it does when I have both feet. So when I go here and I bring this in, this should feel exactly the same. It should feel relaxed, sinking, calm. And then when I lift my leg, it still should feel relaxed, sinking, calm, everything going straight down. So it doesn't matter if it's here, if it's one, if it's both, if it's the other side, if it's here, everything should feel the same structure and that same looseness and relaxing so that you can move. The other thing when you're shifting, you have to make sure that your feet, they should stay flat. So when you shift, the one foot shouldn't come, like the heel shouldn't come up. You may know all this stuff already, but I figure some people listening might not. But if you're going forward, that back foot shouldn't lift. It should still be flat, and the weight transfer should be centered and forward. And then, center and then there. So everything should move to a stable position, relaxed, stable. Then you move, still relaxed, stable, lift, relax, stable in that position, step. So it's the way that they're teaching may not explain those things from a video. So
yeah. So and what like at this stage now the doctors recommend normally to do the weight training, you see, to strengthen your muscles. So what do you how do you differ between the tai chi for developing the muscles to the weight training?
The tai chi is going to develop the muscles, but you're going to develop it through the movements that you use to maintain balance. So if you're just sitting there, doing this, it's different because you're not activating all of those muscles in those pathways, as you move. And your legs will get very strong if you're, if you're really doing it, you'll be sweating and everything else. It shouldn't feel like, oh, this is so easy. It should feel like this is a lot of work, but I have to relax.
Yeah, it's a lot of work.
Yeah.
It's a lot of work if you do it properly.
Yeah.
It is, yeah. Thank you so much for enlightening that this can be used as a therapeutic tool too. Tai Chi, so wonderful. Thank you so much.
You can contact me. I can do some videos with you if you wanted to, if it helps. I mean, I don't know if it would, but.
Yeah. My balance is going now.
Okay.
In spite of doing so much, but my balance really, I am tripping.
Also, when you're stepping, so for Tai Chi, you should be stepping out and out. So you should never step in front because that can lead to a trip. Just like, and when you're going backwards, you're thinking forwards because if you're thinking back as you walk backwards, you're going to put your weight backwards. But if you're thinking forwards as you walk backwards, then you're going to have the intention this way. So the intention of the movement is there as well. And the stepping needs to step in a way so that you don't trip.
Thank you. I'll definitely get in touch with you.
Okay.
Thank you so much. And good day. Yeah.
Thank you.
Over to you, Shalini. Yeah, very nice.
Thank you, Sushma ma'am. Dr. Ravinesh is also with us. Over to Ravinesh, sir.
Thank you, Dr. Seen. Love to see your flexibility and fitness.
Thanks.
So I have seen your all presentations, and I can say the correlation between our traditional system of adaptation and skilling, because nowadays we are using our materialistic tools. It may be computers or anything, but our means elderly persons or in the later in the phase guys are more skilled. And what I feel, this movement disorder is dependent on the age, because our neurological system keeps on affecting our body parts in terms of signaling. It may be our vertebra related issues. So, can we have some techniques, or we can improve the fitness of our athletes? Because most of the athletes getting retired means in the beginner age in early 30s or late 20s. So some kind of as already told by Madam Susma Sharma, this technique is not in very frequent use. So can we have some kinds of a short training programs where we can propagate this techniques, as we in Indian we are promoting Ayurveda in prevention and management of this COVID-19 pandemic. So is there any kind of a training modules for this?
Excellent.
So different training modules. You mean places where you can find how to do this, for instance, or I'm trying to make sure I understand the question. Are you asking like where you can find training for this, or?
No, he's suggesting you. Can we have some kind of training program for the elders, for the athletes, to improve their stability and things like that?
Yeah.
From you, they're asking.
Oh yeah. Contact me, sure. Yeah, I think that would be great.
Yeah.
Yeah, I'm doing one with the Parkinson's group starting in January, and I'm actually going to start doing more with the tremor. I've been so busy with the academic stuff, and then from COVID, it slowed it down a bit. But I'm very happy to get back into it and definitely try to help people out. And the video way has worked out a lot better now, because we've all learned how to do more, over video than we did before COVID. So at least that plus is there.
Yeah.
So, okay. Thank you, Dr. Seen.
Yeah, thank you. Thank you.
Over to Madam Salni.
Thank you, Dr. Ravinesh, sir. Attendees, you may also raise your hand for asking any question. Professor Seen, I have also a question too.
Okay.
Can the tai-chi could be beneficial for treating tremors that is caused due to some side effect of medicines or hormonal imbalance?
Okay. So it's a good question. I guess it depends on which one. I don't know that that's been studied. I mean, there aren't any studies that I found in PubMed or anywhere that had tai chi even for essential tremor, just for Parkinson's, and that wasn't necessarily for the tremor itself. So this is newer things, but even if it's not good in reducing the severity of the tremor itself, or relieving it, it can help in terms of finding ways to compensate. And that's one of the big things we found, because sometimes people just don't think about how to move their body. We're in it all the time, but we don't really consider how things work. Even if it's something as simple as, I can reach this way to open this portion, or instead of moving my arm out, I can turn my body to do the same thing, to close and open, just like you can close and open like this. And just sometimes those small modifications can change the distance someone can reach, or
Mm-hmm.
you know. But for the essential tremor, one of the things is that it tends to be an action tremor. So if the person's at rest, then the tremor may go away. So in that case, you're trying to find a way to be at rest while you're moving. So I would suspect if something else is related to that as an action tremor, then it might be some help. But it, you know, I guess it would depend on what the particular thing is to be able to answer the question. And I don't think there's good data, you know, to show that it could. So it would be something to be explored.
Mm-hmm. Thank you, Professor Seen. I think there is one raised hand. Madam Shivani, can you please let the participant in? Shivani ma'am?
Yes, ma'am.
Can you please let the participant in who have raised their hand?
There is only one student, I think,
Yeah.
Renu.
Renu Arya. Yeah, please let her in.
Dr. Sian, one more thing I saw that if you travel through China Airlines, they had during the flights, they would make you do tai chi, you know, on the plane, so that you don't get your sore back, and you don't, you know, freeze during long flights.
That's pretty cool.
Yeah.
I'd be all for that.
Well, I see a number of Chinese people doing it. What I find is that what they are doing is very complex and too much of movements, you know, quick movements they do. I don't know
Yes.
what is the difference between the different. One is the Qi Kong, which I do, you know, which
Okay,
is very
yeah.
simple, smooth movements, the basic 14 steps, which they say. But the others with those, I don't know, that is advanced or what.
Well, so you have certain principles that everyone should do, but there are different styles for one. So the style I showed in those videos, that was Chin style, and it has more of the fast movements mixed in. But you also have things like straight sword, double straight sword. We do spear routines, and there's a
Yes.
long pole, and you know, there's a lot of there's a broadsword that's a fast motion routine. But some of those things are more related to the martial art part.
Yeah.
So maybe
That looks very complex.
it's fun, but if you have a person that's maybe 85, they might not remember those complex routines. So then you might have to, you know, go back to a shorter routine, or you know, something. But it's good because it does you do get different things from each one. So sometimes the complex things, you'll get different ways to step, different angles to move in, and things like that. So there's a lot of good. The other thing is that, you know, in China they have good practitioners, but then they have practitioners that aren't that good either. So, you know, a lot of times people will say, oh, this, you know, my instructor's Chinese, so they're great. And you're like, that's like saying all Americans are great at basketball. I can dunk anything. So, you know, you have to still evaluate everybody. But I mean, the quality is definitely higher there. Yeah, but
we cannot evaluate because we hardly know. We are kinder
Greetings
students.
to all. Thank
Please,
you,
Shani.
Dr. C. Can I speak? Thank you for giving me this opportunity to ask question from you people. Thank you, Dr. Seen, for describing in such a very well manner. So the question of mine is that, can we use this technique as an intervention, as a novel intervention for treating the peripheral neuropathy?
for peripheral neuropathy. So, I mean, I have had some of my students that did have peripheral neuropathy. Some of the students with diabetes. I don't know. I mean, you could try it, but I don't have evidence to say that that would definitely work. But I mean, anecdotal from some of the people that I've had, you know, they felt better afterwards. Again, that loosening and things like that. But you know, I couldn't say for sure and just say yes, definitely go do it. It's definitely going to help. It would have to be tried out. Sorry.
Okay.
Yeah.
Okay. Thank you.
Thank you, Renu ma'am. Now it's time to say thank you to Professor Sen. Professor Sen, School of Pharmacy and Bhardwaj University is looking for collaboration for the benefit of our students after a discussion with Dr. Yan and you.
Yeah, let's do it.
Okay.
It sounds great. And thank you so much for the opportunity to speak with you all. I love the questions. Very exciting. It's, you know, it's like 10 something p.m. here, and I feel very happy. I'm still at work, and I'm like, yes, this is great. So that's always a good sign. So I really appreciate it.
It is really interesting session. Thank you, Dr. Sen. Thank you.
Okay, so just contact us. We'd love to work with you some more, and ask for some of the articles and potentially doing some sessions for people. So I'll be here. Okay.
Okay.
All right. Thank you so much. Bye.
Thank you.
Thank you.
Thank you.
Thank you to panelists. Shivani ma'am, please let Dr. Jitender Madan in.
It's just now or afterwards? Is it in continuation, Shalini?
It is in continuation, ma'am.
Okay.
Shivani ma'am. Jitender sir, please raise your hand. If you are with us. Jitender sir, Vishal Rana is raising the hand. Is this you? Jitender sir, are you with us?
I'm here, ma'am.
Okay. Welcome, sir.
Thank you, ma'am. Thank you.
Good morning, sir. So, my dear participant, it's time to introduce our next key speaker, Dr. Jitender Madan. Dr. Jitender Madan is Associate Professor, NIPER, Hyderabad. His major research area includes self-assembled supramolecular systems like liposomes, neosomes, and nanoparticles. He has more than 19 years of experience in research as well as academics, and he has published more than 100 papers in reputed journals nationally or internationally. He has also received many times the Best Teacher Award. Now, I request Madan sir to please share his presentation. Over to Dr. Jitender Madan.
A very good morning to all of you. I have already shared my presentation. Is it visible?
Yes, sir, it is visible now.
Okay. So my topic is lipid nanoparticles in drug delivery, use of in silico docking technique in selection of lipid core for drug delivery. Basically, I belong to the pharmaceutics, so I'm presenting my topic in the drug discovery, development, lead optimization. So lipid nanoparticles are very common in the pharmaceutics for the drug delivery, as they are the colloidal particles with a particle size below 100 nanometer, or generally we take this size up to 200 nanometer for the drug delivery through different routes of administration, like intravenous route or topical route, either for the brain targeting. These are actually the finally dispersed particles which enables a penetration into the deep skin due to the nano size. Generally, these lipid nanoparticles are composed of the lipid components which are solid at room temperature, even at the body temperature, that is 37 degrees Celsius. And sometimes we incorporate the liquid lipid with also the solid lipid to form the nanostructured lipid particles, which are generally helpful to encapsulate more amount of the drug as compared to the solid lipid nanoparticles. So in this case, in case of solid lipid nanoparticles or nanostructured lipid particles, we can encapsulate small drug molecules like the drug up to having the molecular weight 500 Dalton. In addition, we can also encapsulate the large biomacromolecules like protein, maybe the insulin one. In addition, we can also encapsulate DNA or siRNA molecule because of but in case of encapsulation of the DNA, there is a need to modify the surface charge over the lipid nanoparticles. So ultimately, these lipid nanoparticles can be administered through the topical route, maybe pulmonary route, oral route, intravenous route, and ocular route. And certain factors we have to decide before deciding the formulation of solid lipid nanoparticles through different routes of administration. The history of solid lipid nanoparticles started with the 1950s, that is the emulsion, which also contains the oil phase. But the major problem with those traditional carriers is the drug leakage, hydrolysis, particle growth, which is generally called the crystallization, and unstable during the storage. So later on in 1991, it was solid lipid nanoparticles were started as the first generation. And later on, we have formulated the nanostructural lipid carriers, as we have discussed earlier, that it is composed of the liquid lipid as well as the solid lipid. So we are, by using the nanostructural lipid carriers, we overcome the drug leakage, which are stable against the hydrolysis and the particle growth, and comparatively stable during the storage conditions. So there are different kinds of the lipid nanocarriers, which are generally composed of the lipids, like maybe the phospholipid or the stearic acid, which is the fatty acid. So we can classify them as different nanocarriers like nanoparticles. If they are composed of the liposomes and the cholesterol, then generally they are called the liposomes. And in case of transferosomes, we can also define as the ultra deformable liposomes. And because they are also made up of the phospholipid, that is the soy phosphatidylcholine, and ethosomes contains the lipid along with the ethanol, and the lipospheres are generally the lipid that is lipid nanoparticles. Niasomes contains the non-ionic surfactants with the cholesterol. Similarly, virosomes, nanoemulsions, which are also made up of the oil phase, and we add the co-surfactant to formulate the nanoemulsions. Again, this is a kind of a lipid carrier system. So what are the different advantages of the lipid nanoparticles? Lipid nanoparticles could bypass the ARIA substrate because of their size. Generally, the ARIA system in the liver, they recognize the particles more than 100 nanometer. So if we will reduce the size below the 100 nanometer, then it is easy for the lipid nanoparticles to escape the ARIA system, and ultimately the half-life of the drug can be increased. So Lipid nanoparticles also provide the high stability to the incorporated drugs which are susceptible to the hydrolysis or any photo stability. And we can incorporate both kind of the drugs, that is the hydrophilic as well as the lipophilic drugs in the lipid nanoparticles. Lipid nanoparticles, because of their uptake by the bile salts through the M cells, they also improve the bioavailability of the poorly water-soluble molecules. So in this way, we can overcome the first pass metabolism of the drug. They can also, because of their high stability, they can easily, we can also sterilize the lipid nanoparticles using the conventional methods. And scale up is also easy. That's why the several marketed formulations of lipid nanoparticles, generally in cosmetics, they are available in market. And lipid nanoparticles also protect. They also protect the drug against the photochemical, oxidative, and chemical degradation of the drugs. Drug leakage can also be avoided because of the crystalline structure of the lipid nanoparticles, which can protect the drug during the to prevent the leakage. And drying by lyophilization also achievable with the lipid nanoparticles. We can easily lyophilize the lipid nanoparticles using freeze dryer. And targeted and controlled release of the drug is also possible. That's why the polysorbate 80-coated lipid nanoparticles are used to target the brain. Because of their biocompatibility and degradability, they are generally used through different routes of administration. So these are the several lipids which are used. To formulate the lipid nanoparticles. That is the beeswax, stearic acid, which is a fatty acid, cholesterol having the steroidal skeleton, caprylic acid, cetyl palmitate, monostearate, behenic acid, solid paraffin, glycerol stearate. And to formulate these lipid nanoparticles, we generally use the certain surfactants like phosphatidylcholine, which is a biosurfactant, and soy and egg lecithin, poloxamers, polysorbate 80, as we have discussed the example of that the polysorbate 80-coated lipid nanoparticles are used for the brain targeting. So if our aim is to target the DNA for the gene therapy, then we can also use the charge modifiers in the lipid nanoparticles to make a stable complex with the DNA so that we can achieve the gene therapy. So these are the different parameters which are used for the characterization of lipid nanoparticles. First is the micromeretic measurements, particle size and shape. So to measure the particle size and shape, we generally use the Jita sizer, which is available with the different companies like Anton Parr and Malvern particle size analyzer. So shape can be analyzed with either the transmission electron microscopy or the scanning electron microscopy. Jita potential is measurement of the Jita potential is also useful for the lipid nanoparticles, because we know that the up to 30 millivolt is the general requirement to formulate a stable formulation. And surface area is also helpful in the drug delivery, measuring the surface area. So apart from that, for the assay of the drug which is encapsulated in the lipid nanoparticles, we use the high pressure liquid chromatography, that is the HPLC method for the assay technique. And apart from that, we can also use the LCMS and FTIR and differential scanning calorimetry. They are also used to characterize the lipid nanoparticle, because during the pre-formulation studies, we use the FTIR and DSC techniques to measure any lipid-drug interaction studies. Apart from that, the X-ray diffraction is also used to characterize the crystalline structure or crystalline geometry of the lipid nanoparticle. Generally, lipid nanoparticles, because of the presence of the moisture water molecules, they are amorphous in nature. And dermal irritation assays are generally carried out in either the rat skin or the rabbit skin as per the OECD guidelines. So generally lipid nanoparticles, they are not irritating in nature. No, they are non-irritant. And apart from that, we use measure the spreadability and the rheological features of the lipid nanoparticles. If we are making any kind of the gel by using the lipid nanoparticles, using texture analyzer or viscometer, And stability is generally carried out for the lipid nanoparticles as per the OECD guidelines at the 40 degree and 75% relative humidity. So these are the different features which can be used to modify the lipid nanoparticles as per the route of administration. So we know that we can encapsulate both hydrophilic and lipophilic drugs in the solid lipid nanoparticles. So definitely after encapsulation, the drug entrapment can be improved, and which can be helpful in the drug delivery to the different sites in the body. Apart from that, after making the surface modification, for example, DNA is negatively charged, and if we will modify the lipid nanoparticles with certain kind of surfactants having the positive charge, then it is easy for making a complex between the lipid nanoparticles and the DNA, which can be helpful in the gene therapy. For the improved cellular uptake in the cancerous cells, we generally make the lipid nanoparticles below 100 nanometer, because below 100 nanometer size is optimum for the cellular uptake of the nanoparticles in the cancer cells. So this will help in the APR effect, and we can also increase the viscosity of the gel if we will incorporate the lipid nanoparticles in the gel, which is called the nanogel. We can also encapsulate two kinds of drugs in the same lipid nanoparticles, so it can be which can be further helpful in the synergism. And after encapsulating the drug in the lipid nanoparticles, definitely the side effects will be minimized because of the change in the volume of distribution of the drug. So these are the applications of the lipid nanoparticles in drug delivery. So as we have discussed earlier, that is the lipid nanoparticles are useful in the brain delivery, as we have quoted the example of that is the polysorbate 80-coated lipid nanoparticles. Apart from that, because of the presence of the function group in the fatty acids, that is the carboxylic end, we can also conjugate any ligand like folic acid or any other ligand having the primary amine group by making the amide bond with the lipid nanoparticles. Apart from that, as we have discussed, that the lipid nanoparticles, they can also be used for the passive delivery of the anti-cancer drugs to the cancer cells. Antimicrobial drug delivery, generally the antimicrobials are highly, they are the substrate for the P pumping glycoprotein, which is called the PGP. So to overcome this kind of the drug resistance, we can use lipid nanoparticles. We can encapsulate the antibiotics in the lipid nanoparticles to overcome the drug resistance. Topical drug delivery, generally lipid nanoparticles are amalgamated with the conventional gel, which are made up of the carbopol, to increase the uptake of the lipid nanoparticles in the deep skin tissue. In addition, controlled release of the drug is also possible with the lipid nanoparticles because it will increase the half-life of the drug. Apart from that, as we have discussed earlier, certain lipid nanoparticles, they are also reached the market, especially in the cosmetic market, because of their high compatibility and cost effectiveness, and they are also increase the biocompatibility. So different methods of formulation of lipid nanoparticles are available. Some are also used by the industry for to scale up the lipid nanoparticles. So among these, high shear homogenization, ultrasonication or high speed homogenization, cold homogenization, hot homogenization, microemulsion based methods, supercritical fluid based methods, solvent emulsification, evaporation methods, or double emulsion methods. Generally, at the lab scale, we use the solvent emulsification methods or solvent evaporation methods to formulate the lipid nanoparticles. On the other hand, if we are going to the industry, then they use the high shear homogenization method or the microfluidization method to formulate the lipid nanoparticles. In case of microemulsion based methods, we can reduce the size below 100 nanometers because generally microemulsions are produced at the lower size. So this is the nanospray drying technique. So in case of nanospray drying, this is the industry feasible method in which the dry powder material can be produced by atomization through an atomizer into the in presence of the hot drying gas. So because of this easy approach, scale up of the lipid nanoparticles is possible with this spray drying method. So because of the so we can produce the lipid nanoparticles at the very cheaper cost using nanospray drying method, and it is the scalable and reproducible methods. So heat stable or the heat sensitive drugs can also be scaled up with this nanospray drying method. Encapsulation efficiency of the drugs within the polymeric carriers can also be increased by using this method, and it is widely used for the pharmaceutical and chemical materials, especially in the cosmetic and the food industries. This is the hot melt extrusion method. This method is also available in the Nipah, Hyderabad. So it is a continuous pharmaceutical process that involves the pumping the polymeric material with a rotating screw at the temperatures above their glass transition temperature, or sometimes at the melting temperature, to achieve the molecular level mixing of the active components in the polymers. So in this case, generally we fuse the polymer with the drug, and because of their melting, it produces the amorphous. It induces the amorphization of the drug within the polymer. So because of this hot melt extrusion method, which is a continuous process, so there is we are not using any organic solvent here. So it is also called green chemistry. It can be also covered under the green chemistry or green method. So it is a solvent-free method, and it is a quick and cost-effective manufacturing process. So in today's presentation, generally we will focus on the application of lipid nanoparticles in the skin. So generally, to use through the topical route of the drug administration, we encapsulate the drug-loaded lipid nanoparticles within a conventional gel. So that's why it is called the nano gel. So there are several mechanisms have been established how the lipid nanoparticles penetrate the deep tissue. So among these is the intracellular pathway, which is also called the transepidermal pathway or transfollicular pathway, and through the sweat gland. So certain factors affect the skin permeation of the drug. So if we are formulating the lipid nanoparticles up to 600 nanometers, so as it is appearing in the figure that up to 600 nanometer particle size will reside in the epidermis layer of the skin. So if we are formulating the 100 nanometer particles, then there might be the chance that it can cross through the that is the dermis layer. So if we are considering the case of osteoarthritis we are considering the case of osteoarthritis, we know that the osteoarthritis occurs in the joint, which is a joint disorder. So we need to formulate the lipid nanoparticles up to 100 nanometer, and accordingly we have to select the lipid core so that we can achieve this kind of the particle size. So zeta potential. So zeta potential is the potential difference. It can be defined as the potential difference between the dispersion medium and the stationary layer of fluid which are attached to the dispersed particles. So zeta potential generally provides the information about the surface charge, and it also governs the stability and the shelf life of the colloidal dispersion by determining the degree of the repulsion forces. So cellular surfaces are dominated by the negatively charged sulfated proteoglycans. We all know that either the skin cells or the cells are generally, because of the presence of the phosphatidylcholine, they are the negatively charged. So if we will formulate the nanoparticles with the positive charge, then it is then there might be the chance that we can increase the permeability of the lipid nanoparticles through the skin or through the cell membrane. So that's why lipid nanoparticles, they are also helpful to increase the permeability of the poorly permeable drugs. So that's the cationic compounds or the nanoparticles with the surface charge. They strongly bind to the cell membrane and showed a higher cellular uptake and better skin permeation as compared to the anionic nanoparticles. So my talk is basically based on how we can select the lipid nanoparticles which can show the high permeability. So that's why we have considered the case of the in silico docking, how in silico docking can help us to select a particular lipid to formulate the lipid nanoparticles. So we know that generally the skin is composed of the lipids in addition to the water. So ceramides is the main component which is present in the epidermal layer of the skin, which also acts as a barrier for the skin, barrier to the drug delivery. Apart from that, cholesterol and free fatty acids are also present in the skin layers. So these are the different components. These are the composition of the different layers. For example, in case of stratum corneum, lipid matrix, corneocytes, they are also present, having the dimension is 10 to 20 micrometer. So in this way, the stratum corneum acts as a barrier to the diffusion of the drug into the deep skin tissue. So how we can select the lipid nanoparticles which could increase the permeability of the drug? Definitely, the lipid should be solid at both room temperature and at the body temperature. High crystallinity of the lipid leads to lower drug loading, so that's why there is a need to add some kind of surfactants which could help us to promote the amorphization of the drug within the vicinity of the lipid nanoparticles. So liquid lipid can also be selected to formulate the analysis, as we have discussed earlier. So solubility of the drug in the lipids governs the drug loading and the encapsulation efficiency. So in summary, we can use the in silico docking techniques to select the particular lipid to formulate the lipid nanoparticles or to increase the permeation of the drug across the skin. So this is the literature which is available on the PubMed, in which they have used the simulation techniques to overcome the drug permeability. So they have used the gold nanoparticles or the lipid nanoparticles to increase the permeation of the drug. So lipids which are available for preparing the lipid nanoparticles, as we have discussed earlier, that is the fatty acids, alcohols, esters, amines, and glycerides. So all these lipids with the different functional groups are generally considered to formulate the lipid nanoparticles. So when these lipid nanoparticles we will apply over the skin, which are amalgamated with the gel. So because of their interaction with the ceramide, which is the major component of the stratum corneum, and this interaction will allow the lipid nanoparticles, which is encapsulating the drug, to the deep skin tissue. So generally lipid nanoparticles, they penetrate the epidermis layer of the skin by disruption of the lipids or the fluidization of the lipids which are present in the stratum corneum, which ultimately leads to the enhanced permeation of the drug within the skin tissue. So this is the case study. Recently, this paper has been published from my group, in which we have selected a model drug, that is the meloxicam, which is an anti-inflammatory drug and COX-2 inhibitor. So COX-2 inhibitor we have selected because of the COX-2 is present in the skin after induction of the inflammation. So we have formulated the meloxicam loaded solid lipid nanoparticles, and after that we have incorporated those meloxicam loaded solid lipid nanoparticles with the gel, and we have studied the lipids with having the different chain lengths and the functional groups to determine the permeability, and in that way we have optimized the structure, that what kind of structure of the lipid is required to achieve the maximum permeability through the skin. So after applying the lipid nanoparticles, they penetrated into the deeper layers of the skin via transfollicular route, and in this way we have achieved the maximum concentration of the drug within the deep skin tissue to overcome the various pro-inflammatory cytokines which are generally present in the osteoarthritis. So this is all about the insight of this present research work. We formulated the solid lipid nanoparticles with the objectives to screen the lipids for enhancing the permeation based on the in silico docking techniques. And after carrying out the in silico docking techniques, we have carried out the experimental. We experimentally formulated those lipid nanoparticles and studied the permeation of the drug using the French diffusion cell, which is label which is generally used to measure the skin permeation of the drugs. So after that, we have also correlated both the data, that is how the functional group can help us to select a particular lipid nanoparticles to increase the permeability across the skin. So this is the main base of this case study. So what we have thought that the interaction between the lipid core and ceramide is essential to achieve the greater permeation. And we have used the energy minimization using OPLS 3/4 field of the LickPrep module from the Schrödinger study. We have taken the help of the chemistry department to carry out this study. So ceramide was docked using the ligand. Here ligand means that is the lipid, particular lipid core using the docking guide. So ceramide were extracted from the protein crystal structures. So as we are presenting the slide that we have used the palmitic acid with a functional group, that is the carboxylic acid, stearic acid, arachidic acid, bionic acid, and apart from that, we have taken the different functional groups: stearyl alcohol having the OH group and the stearyl amine having the primary amine group. So we have taken the lipids with a different chain lengths, that is the palmitic acid having the chain length C16, stearic acid C18, arachidic acid C20, and bionic acid that is the C22, and the lipids with the different functional groups, that is the stearyl amine, that is the amine, alcohol, and acid. So here we have taken two kinds of lipids, the lipids with the different chain lengths and the lipid with the different functional groups. So after making the docking or calculating the docking score, it was appeared that the stearyl amine, because of the presence of the amine functional groups, it has interacted more with the ceramide. It has interacted more with the ceramide of the statoconium as compared to the other lipids. Apart from that, we have also established a parabolic relation in which we have seen that the stearic acid, which is the C18, has shown the optimized or have shown the maximum permeability as compared to the rest of the lipids. So after that, after screening the lipids, now we have screened that the stearic acid and stearyl amine both we have optimized through the in silico docking techniques. After that, we have formulated the lipid nanoparticles of both the lipids using meloxicam as a model drug by solvent operation method, as we discussed earlier that this is the lab scale method. So we have dissolved the lipid phase and the surfactant solution and heated to a temperature above the melting point of the lipid, which is generally the 70 degrees Celsius. And after making the lipid nanoparticles, we have characterized these lipid nanoparticles for the particle size, zeta potential, entrapment efficiency, and the drug loading, as well as the surface topography by the time instrument. And after making these lipid nanoparticles, we have encapsulated these lipid nanoparticles into the chitosan gel. Chitosan is a well-known polymer and already approved by the US FDA for the topical application. So after that, we have also characterized these lipid nanoparticles for the drug content and the ex vivo skin permeation studies for the optimization. So this is the particle size of the different lipid nanoparticles in addition to the surface charge. So we obtained the particle size in the range of 152 to 246 nanometer with a polydispersion index lower than 0.3. So on the styroamine lipid-based nanoparticles, they have shown the cationic charge instead of the rest of the lipids, which have shown the negative charge. So after characterization, so based on the characterization, we have seen that the antipenem efficiency was maximum with the behenic acid and the stearyl alcohol and the stearic acid. We all they have shown the antipenem efficiency more than 90%. And similarly, we also obtained the good drug loading. So that's why the antipenem efficiency, because of the high solubility of the meloxicam, those lipids, we obtained the antipenem efficiency in the range of 89 to 97%. So good antipenem efficiency ensures the good drug loading, so that's why the drug loading was achieved in the range of 9.1%. Despite the high antipenem efficiency, the drug loading was quite low for the lipid except the styroamine. The pattern of the drug loading was in the line with the drug solubilizing capacity of the lipids. So we have carried out carried out the ex vivo skin permeation studies to correlate the data with the in silico docking techniques. So we have seen that we have measured the flux values of the ex vivo skin permeation studies. So as it is appear in the table that we obtained the maximum flux values with the styroamine as we obtained in case of the in silico docking techniques. So styroamine among all these lipids found to be more suitable for the deep skin permeation as compared to rest of the lipids as it was appeared in the in silico docking data. So after carrying out all these characterization parameters, we carried out the in vivo studies by inducing the knee osteoarthritis in the rats using the monoiodosodium acetate, using the monosodium iodoacetate, which is a well-known model to induce the knee osteoarthritis in the rats. So we have taken the different groups, that is the normal control, disease control group. So we have taken the group that's for meloxicam oral dispersion and meloxicam intravenous group. And we also applied topically our prototype lipid nanoparticle gel. And we have compared the efficiency of our gel with the commercially available ethoric oxide gel and the diclofenac marketed gel. In addition, we have also compared it with the blank gel. So it was appeared that our formulation, which is the topical meloxicam gel, they have shown the equal effect as compared to the meloxicam oral or meloxicam intravenous administration, as it is appear in the graphs. It reduces the knee joint, that is the thickness, equally to the meloxicam oral and meloxicam intravenous groups. So similar results we are also obtained in the histopathology, which indicated that because we have used the toluidine blue dye to stain the cartilage, which is the major marker in the osteoarthritis. So because of the absence of the cartilage in the positive control group, which is the disease control group, so the cartilage was not appeared in this group, whereas in case of the normal group, because of the presence of the cartilage, it shown the blue staining. And the same in the case of the meloxicam oral, meloxicam intravenous, and meloxicam gel, they have also shown the protection again of the cartilage degradation. On the other hand, the ethoric oxide gel and the diclofenac gel, they did not show any kind of the cartilage protection. So, which is an important marker in case of knee osteoarthritis. So similarly, we also measured the interleukin-1 beta and TNF-alpha, which are the pro-inflammatory cytokines, which are the pro-inflammatory cytokines which generally appear in the synovium of the osteoarthritis patient. So our formulation, which was applied topically, they have shown the equal effect as compared to the meloxicam intravenous and meloxicam gel for meloxicam intravenous and meloxicam oral formulation. So this was the conclusion of the study, that screening of the lipid for the skin permeation can be carried out in silico docking studies. So in this way, in silico docking studies can help us to reduce the number of experiments, and we can correlate the in silico docking data with the experimental studies. So on the other hand, lipid chain length exhibited the parabolic relation with the docking score and the flux values, which indicated that not all the lipid chain lengths are, we could not increase the permeability of the drug with the higher chain length. Only an optimum chain length can help us to permeate to allow the permeation through the skin. And after optimization, it was appeared that, and from the in silico docking data also, that a main functional group of the lipid exhibited the highest flux than alcohol and acid groups because of the presence of the positive charge. So in the end, we can say that the meloxicam loaded solid lipid nanoparticle jet showed the comparable efficacy to the meloxicam oral dispersion in elevating the pain and inflammation, which is allied with the osteoarthritis in the Western rats. So this preclinical studies proved that we can effectively use in silico docking studies to reduce the number of experiments and to reduce the cost of the treatment for formulating the any novel product. So these are the references which were published from my group. Thank you very much. Thank you.
Thank you, Dr. Madan, for sharing or giving insights on lipid nanoparticles for topical drug delivery. Now, I may please request our panelists to start the Q&A session. In our panelists, we have with us Dr. Ravinesh Mishra and Sushma Ma'am. Over to Sushma Ma'am. Shivani Ma'am, please let Sushma Ma'am in.
Hello. Good morning, Dr. Madan.
Good morning, ma'am.
Good morning. Excellent presentation. And your presentation shows the amount of work you have done, put into the nanoparticle. Well, my question was about the cancer. How can this lipo nanoparticles be used for the targeted therapy also? Or it would be just delivering an cancer drug?
Ma'am,
what is your pick on that?
Yes, ma'am, we can use it for the targeted therapy also. For example, if we will conjugate the folic acid over the lipid nanoparticles, then folic acid can be used as a ligand to direct the anti-cancer drugs to either the cervical cancer, which overexpress the folate receptors, or the ovarian cancer cells, which also overexpress the folate receptors.
Okay.
So in this way, we can change the volume of distribution of the drug, or the biodistribution of the drug.
That's wonderful. But then it will be, but it has to be given parenterally only, no?
Yes, ma'am. Through intravenous route of administration, we can use it, these lipid nanoparticles for the drug targeting.
But my question is, this lipid nanoparticles to be given intravenous, or it has to be intramuscular because it is lipid?
No, it is given by the intravenous route, but we have to control the size of the lipid nanoparticles. So it should not cause any kind of the embolism in the veins. Otherwise,
this
it
is
may also
exactly
cause
what
the stroke-like conditions.
because very fine. Because oil intravenous, I have never heard. It used to be no, or with the nanoparticles shape.
Ma'am, in case of if we are delivering any vaccine, then we can use select the intramuscular route. But for drug targeting, we use it through the intravenous route. Ma'am.
Okay, thank you so much. Yeah, wonderful. Very nice.
Thank you. Ma'am.
Can anyone else? Does anyone else have a question, please?
Yes. Thank you, Dr. Madan, for delivering such a nice lecture with respect to the role of lipid nanoparticles in drug discovery.
Thank you, sir.
So, can you let us know about what are the various in silico tools we are using for targeting these techniques?
Dr. Ravinesh, you know that I belong to the pharmaceutics person. So we have taken the help of chemistry department, which is located in our Naipur, Hyderabad, for carrying out this in silico docking techniques. So if you ask any question from the pharmaceutics, then would be happy to reply your question.
Right, sir. Sir, can you let me know this lipid nanoparticle is only for the drugs which are having low solubility, or we can also deliver the drug which are having the higher solubility?
Good question. We can incorporate both kind of the drugs, as I have also shown in my presentation that we can encapsulate hydrophilic drugs as well as the lipophilic drugs in lipid nanoparticles. But in case of lipophilic drugs, which are the poorly soluble, we can achieve the maximum entrapment efficiency as compared to the hydrophilic drugs.
Okay, sir. Thank you. Thank you for accepting our invitation and your constant and continuous support with respect to whatever I have asked as on date to you. Thank you, sir. Over to Madam Salni.
Okay. Thank you, sir. Thank you much.
Thank you, sir. Thank you, Sushma ma'am. Shivani ma'am, there are some raising hands. I'm looking. Please let them in one by one for asking questions.
Yes, Vinay Kumar, please click on your mic.
Hello.
Yes, Vinay, you
Hello.
are audible. Yes, Vinay, you can ask question.
Good morning, sir. My question is that we know that after formulating nanoparticles, the bioavailability increases several fold. Then how do we select like oral dose, or if we have to administer any intravenously? How do we select that?
We select the dose of the drug based on the loading capacity, drug loading capacity. Suppose if in case of the rats, if you are giving the drug through 10 milligram per kg, then according to the body weight of the rat, you have to calculate you can calculate the dose of the drug according to the drug loading capacity of the lipid nanoparticles, not through the entrapment efficiency.
Okay, sir. Thank you. Thank you very much.
But sir, will the dose be less in case of the nanoparticles, or
No,
it remains the same?
No, ma'am, dose will remain the same, but it might be the chance that we can achieve maximum therapeutic efficacy after encapsulating the drug in the lipid nanoparticle as compared to the pure form of the drug.
So the metabolism also will be reduced, it means, huh?
Yes, ma'am. Yes, ma'am. Yes, ma'am. We can also increase the circulation half-life of the drug. So the dosing frequency can be reduced.
Yes. Okay, wonderful. That's a lovely thing. Very nice.
Thank you.
How about the oral preparations in nanoparticles? How about the absorption with the nanoparticles?
Generally, lipid nanoparticles, they form the micellar structure with the bile salts. So in this way, we can also overcome the first pass metabolism of the drug. They do not directly interact with the intestinal absorption window. Generally, they are taken by the M cells, which is the lipid uptake that is called.
Okay.
Okay, Ma'am Shivani, kindly let other participants in.
Yes, ma'am. Vanna Sharma, you can ask the question.
Yes, ma'am.
Yes, Vandana ma'am, you are audible. Please ask your question.
Good morning, sir. Dr. Madan.
Yeah, good morning.
My question is, what is the state of the drug inside the solid lipid nanoparticle? As the drug is solid at room temperature, and if the melting point of the drug is higher than the melting point of the lipid or any other surfactant we used for preparing the solid lipid nanoparticle, so is it dissolved in the fluid, or it will form a dispersion?
Ma'am, if your drug is soluble in a particular lipid, for example, we have taken here the example of meloxicam. So meloxicam we have dissolved in the sterile amine, which I have shown in the data. So because of this dissolution or presence of the moisture within the lipid, so it causes the amorphization of the drug. So we know that the amorphization of the drug increases the drug bioavailability, but sometimes it reduces the drug stability. But the overall structure of the lipid nanoparticles, as they appeared in the XRD, it shows that is a crystalline structure, but the internal structure of the lipid nanoparticles is somewhat amorphous as compared to the crystalline structure.
Okay. Thank you, sir. So one more question from my side. Can we encapsulate two different compounds together in solid lipid nanoparticles?
Yes, ma'am. That's why I've written that the core delivery. So we can encapsulate two kinds of the drugs, two different kinds of the drugs, and the lipid core.
Okay. Thank you so much.
Thank you, ma'am. Thank you very much.
Next question, Shivani ma'am, please let another question in.
Yes, Miss Renu Arya, please ask your question.
Good morning, sir. Thank you for this wonderful presentation that you have gave to us. My question is that we can give solid lipid nanoparticles orally and topically, right? We can give this in a both route. So tell me, can you just describe me about the bioavailability, which would be the best if we talk about the bioavailability?
Ma'am, in case of bioavailability, if your drug is susceptible to the first pass metabolism, then in that case we can choose lipid nanoparticles to overcome this first pass metabolism. Secondly, we can also administer these lipid nanoparticles, as we have discussed earlier, that through the parenteral route of administration. So we can also increase the circulation half-life by making the pygylated lipid nanoparticles. Pygylated means we can conjugate the polyethylene glycol with any fatty acid, that is the solid lipid, to increase the circulation half-life of the drug.
Okay, sir.
But then how does it bypass the liver? First bypass the liver.
Ma'am, first pass metabolism, if you are administering the formulation through the intravenous route of administration, then there is no issue of the first pass metabolism. But if in case of through oral route of administration, it will be directly taken up by the lymphatic system, not through directly through the intestinal absorption window.
Okay. Next question, please. Shivani ma'am. Next question, please.
Yes, ma'am. There is no one.
Okay.
No one else?
Yes, ma'am. Please continue.
Still, I can see some more hands.
Yes, it is visible to me also. Some more hands are raising. Okay.
A
Thank
lot
you,
of
sir.
work has been done by Dr. Madan. Great. Very
Thank you,
happy
thank
to
you
see.
much. Thank you,
Thank you,
Wonderful.
sir. Thank you so much.
Thank you, ma'am.
We will surely see again.
Okay, thank you, ma'am.
Get in touch with
Thank
you
you.
for
Yes, sir.
research. Yeah, thank you so much.
Thank
you,
you,
ma'am.
sir.
Thank you very much.
Thank you, sir.
you.
Thank you, Sushma, ma'am.
My pleasure.
Thank you, Ravinesh, sir. Now it's time for a short break. It's 9:40 and we will meet again at 10:40 for the next session. We'll have a breakfast break now and we
So
will meet at
what are you eating for the breakfast?
yes,
Charlie,
ma'am.
क्या खिला रहे हो? Challenge.
Okay.
हाँ? कुछ कह रहे हो आप?
नहीं, ma'am.
Have a. हाँ.
Okay.
We'll see.
Thank you, ma'am. Thank you. Okay, ma'am. Thank you, participants. And be with us at sharp 10:40.